about a different. We'll be talking about seizures. Okay. Okay. And so basically, just a summary of what you know about seizures. Seizures are kind of like events, like they're like events that are characterized by, synchronized high firing neurons, synchronized electrical activity, synchronized high firing neuronal activity. Okay, so what basically happens here is that the brain is basically sending out a lot of signals, okay? And they're kind of synchronized. So this is just a summary of what you guys already know about seizures. And ordinarily, anything can present as a seizure. So a patient can have eye twitching, can have an absence of, can have prolonged movements, can have basically anything, okay? And it can present as a seizure. So basically, for the sake of the summary and what we know, we have two types of seizures, basically. Okay, so we have simple, right? Or you can call it focal seizures. Focal. Okay. And then we have diffused or we have generalized. Just something basic that you guys always know, okay? And then the simple or focal seizures are usually from the word simple or focal. It means that a particular brain or part of the brain, particular area of the brain is affected. So let's say this is, the ventricles. Okay. So let's say this particular part of the brain, let's say this part of the brain is affected. Okay. So this kind of seizure that to present, it's a focal seizure. Okay. Right. But for example, if the seizure involves a wider area or multiple areas or a greater portion of the brain, it's called a generalized seizure. Now, the first thing you need to understand about these two is that the first thing is that a localized part of the brain is being affected, and then a wider area of the brain is being affected. And this focal seizure can also be characterized into two parts, right? We have the simple partial, okay, and we have the complex partial, okay? And then usually the part of the brain that is affected in a focal seizure, the most common part actually is the temporal lobe. You must know this is very, very high yield. Okay. Temporal lobe. Right? And so there's some questions that can come in this way that, okay, the most common part of the brain that's affected in a seizure is the temporal lobe. They usually ask which organism is quite peculiar for causing a temporal lobe, medial temporal lobe seizure. So medial temporal lobe seizure. And the most common cause. What did you say, Doc? Hello, Doc, I didn't hear you.
Sorry, I think you asked about what is the organism that affecting the temporal. This is herpes simplex virus.
Yes, exactly. So herpes simplex virus is what affects the temporal lobe. That's great, Dr. Jamil. Herpes simplex virus is the common causative organism that causes medial temporal lobe seizures. Herpes 1. So don't forget that it's herpes 1, not herpes 2. Herpes 1 is the major organism that causes that. It causes medial temporal lobe encephalitis as well. So you need to know that that's also very high yield, right? And then we need to understand that seizures can present in various ways, okay? Like I said, they're usually for the focal seizures, especially for the simple focal seizures, the patient's consciousness is intact. So let's say there is no LOC, right? Right. But for the complex, the seizure for a patient who has complex partial, the patient initially starts as a simple focal seizure, but over time, there becomes what we call secondary generalization. So hence, it might start from a particular part of the brain, then spreads to other region. And in some circumstances, the patient might have loss of consciousness. Okay. Usually, a seizure is supposed to last probably as low as maybe 2 seconds to as much as 2 minutes. Patients can have a seizure that lasts up to that duration. Okay. And then what you need to know for the exams, especially for the step one, is that you need to know the differentiating factor between these two. Okay. You need to know that for the simple partial, the patient has no loss of consciousness. And then for the complex partial, the patient might start as a simple partial, but there will now be secondary generalization. Hence, the patient will present with loss of consciousness. So you have to know that as well. And then when you know this, you will now be able to differentiate this from the diffuse. So the diffuse, like I said, covers a wide area, okay? And then the diffuse or the generalized has other parts, other uh, types of seizures under it. So we have the tonic-clonic. This is just a recap because basically I think everyone knows about seizure disorders, okay? Tonic-clonic, and then we have clonic, we have tonic, we have tonic-clonic, we have atonic, right? And we have myoclonus. Can anyone tell me what condition does a patient have myoclonus, especially status myoclonus? What condition does the patient present with status myoclonus? Can anyone tell me?
Fruits, Jacob.
Yes, because Jacob syndrome can also cause that. Yeah, yeah. Okay, so okay, I'll look at the job box later. Okay. So for the atonic seizure, the patient has for the myoclonic seizure, the patient just has sudden jerky movements. These sudden jerky movements are very, very brief. Sometimes can be sustained. Okay, but for the atonic seizure, the patient has a sudden drop. Okay, sudden drop or sudden loss of consciousness almost immediately. And sometimes in the question, we usually confuse this with syncope. So there's a difference between atonic and syncope. So for syncope, the patient falls to the floor. The patient actually loses consciousness, but the patient's recovery is quite sudden as against atonic. So for atonic seizures, the patient doesn't resume quite almost immediately, right? There's still this little disorientation for some minutes before the patient gains full consciousness as against a syncope. Okay. Now we need to know what status is. I think can anybody tell me what status and epilepsy is? Can anybody tell me what the difference between status and epilepsy? Status epilepticus and epilepsy. Can anyone tell me the difference?
The
Yes,
patient
yes.
suffered with epilepsy episode and it's prolonged more than 5 minutes. And
Yeah.
patient with the next episode, he will not recover from the previous episode. Means he will in still in what you say ictal condition, and the next episode also happened.
Yeah. So in status, so yes, you're right, Dr. Jamil. The patient is
The
convulses for
third
a long.
third criteria also, then it's prolonged more than 30 minutes now, repeatedly
Yes.
also.
Okay. So what's the difference between status epilepticus and epilepsy? So what's the difference? What is the definition of epilepsy?
In epilepsy, there is like it's a single episode or it's episode for a short time and the patient recovers. There are three stages, so like pre-epileptic shape and ictal stage and post-ictal stage. And then patient recovered from this stage. Maybe after 30 minutes, he will keeps sleep and then he fully recovered from that condition in epilepsy. But in status, he will not recover from what you say the ictal state,
Yeah.
and then the next episode happen also.
Yeah, so you're right. So there's a level of recovery in a patient who has epilepsy as against status, meaning that the patient has two seizures in between. First of all, an epilepsy is just two unprovoked seizures Usually the authorities say about 24 hours apart, basically. So, but in epilepsy, the patient returns to baseline level of normality. But in status epilepticus, the patient doesn't return to that stage. So, yes, thank you, Dr. Jamil. Okay, so now we need to know the different causes of seizures. So we have different age groups for children or for adults less than 18, and then for adults 18 to 65, and then we have for individuals greater than 65. So the mnemonics I use for this is GIT for children, the causes of seizures in this age. So the first one is genetics. The common causes, of course, these are common causes. Genetics, right? And then the I is infection. So this is the common cause of seizures in individuals less than 18. Of course, infections are the most commonest for usually children greater than the age of 2 upwards. For genetics, it's usually around the first 2 years of life. Then the last one is trauma, very rare cause though. But so the mnemonics I use to remember it is GIT. Of course, these are causes of seizures in children less than 18, basically, or individuals less than 18, common causes. But for adults who are greater than 18 to 65, of course, the common causes include the patient presents with tumors, patient presents with trauma, and then the patient presents with a stroke. Okay. Okay. You just need to know 3. You don't need to know all, or you just need to know the most important cause among them. So in this stage, tumor is one of the common causes, as well as trauma. Stroke can occur, but not as common as these two. Then for greater than 65, for patients who are greater than 65, stroke is the commonest cause. Okay. Stroke is the commonest cause. Let's just stick to the simple things. Okay. Now, of course, there's one more thing that we need to talk about, one more important type of seizure that we need to talk about. And it's a type of seizure that is quite unique in its own way, okay? And it is called absence seizure. Does anybody have an idea of what happens in absence seizures? How does the patient present? What is the trigger? Because this comes out a lot in the exam. And how do we treat it? What medication do we use to treat it? Okay, absence seizures.
I think this is going to be mostly found in kids, usually younger toddlers, and they just stare into space. They're not
Yeah.
responsive to stimuli or anything. You call their name, you tap them, they're only just staring blankly, but they're not really seeing anything. And then they recover after a couple seconds. As for the drug, I think is ethosuximide. As for the etiology, I'm not sure what could lead to it yet.
Okay. So a lot of the times, usually, most of the causes of seizures are usually unknown. But basically, what we do know, sometimes it can also be idiopathic. Okay, also be idiopathic. But you're right. So it occurs in children, basically, usually toddlers and school-age children who go to school. And usually the presentation is that the child just stares into space for a while. And then when you try to call the child's attention, the child doesn't respond. You call his name several times, he doesn't respond. And then after some couple of minutes to seconds, the patient now, gets back himself, and then he's able to respond to you, he's able to talk to you. And a lot of parents usually feel that the child is maybe absent-minded, doesn't do well in school. They actually think that the child is playing a lot, but meanwhile, the patient just has an absence seizure. So what do we see on ECG when you do an EEG? Rather? What do you see on an EEG? What do you see on an EEG for a patient with absence seizure?
Classically, it's like 3 hertz spike. I think that's what I can remember.
Yeah, so it's a 3 hertz slow wave spike. Slow. So it's slow wave spike. Yeah, thank you, Doc. Slow wave spike. Okay, so this is what you see on EEG. This is very, very high yield. This this wave that you see is high yield for step 1 because they ask it a lot, right? Knowing the drug of treatment as well is also very high yield for step 1 because they ask this a lot. Yeah, so I think that's just a brief summary of seizures. Do we have any questions concerning seizures? Of course, it's not really something that we should dwell so much on. Seizures are high yield, but not so high yield. I wouldn't put them as like top high yield topics.
Doctor, could you please explain the clonic, the tonic-clonic, and then the clonic ones, the terms?
Sorry, I didn't get your question. What did you say?
Could you please explain the clonic, the tonic, and then the tonic-clonic, like form, the terms? How they...
Okay, yeah. So let me go over that again. I guess I was too fast here, so let me explain that again. So for the clonic, I think I should just use a picture to describe it. I think it's a lot more easier. Okay. So for the clonic, basically, the word clonus means sustained contraction, right? The patient is having jerky movements. So what happens in clonic, let me just put it like this. So this is clonic, right? For clonic seizures, the patient has jerky movements. I mean, the patient might jerky movements on an extremity. Okay. So the patient jerks and then stops, jerks and then stops. So there's like there are brief pauses. Brief pauses. So the patient jerks, and then stops. The patient jerks, and then stops. So it's like they're in between pauses between in a patient with clonic seizures, right? Clonic seizures. I don't know if you guys have seen someone that's vibrating, like someone that's vibrating. There are a lot of people that can be very angry and then they start having these vibratory motions of their hand. The hand just keeps moving. Some people might call it a tremor. It looks like a tremor, but it's not really a tremor. The patient is vibrating the whole of the left limb. I don't know if you guys have seen a seizure happen before. I don't know if you guys have a clinical view of how a seizure happens. For the clonic, the patient just jerks, keeps jerking, vehemently. As against myoclonus. Myoclonus basically is a form of clonic seizure that occurs usually in the upper limb. So it's usually an upper limb type of seizure. Okay, upper limb type of seizures. And then in this kind of situation, the patient has more of a sustained, so it's more sustained jerking without a pause. Right? Sustained jerking without a pause. So the patient jerks, but doesn't have a pause in between, unlike clonic seizures. Clonic seizure, the patient has a brief pause. So he jerks for about 1 or 2 minutes, stops, and then continues jerking again, right? But for the myoclonic seizures, it usually affects the upper limb, more of the upper limb than the lower limb. The clonic seizure, you can also have a clonic seizure in the leg. You can also have it in the arm. But the myoclonic seizures are more common in the upper limb. So they're more common in the upper limb. And they tend to be more sustained than the clonic seizure. I don't know if that answers your question.
Yes, thank you.
Okay. So Dr. Aisha, I'm talking about seizures. Yeah?
Can you tell about focal aware seizures?
Okay, I didn't talk about focal seizures.
Focal
Dr.
aware,
Nafia,
what happens in them? What happens
okay,
in
so
the focal awares?
okay. So if I get your question correctly, you mean that I didn't explain what happens in focal aware or focal or complex partial? Is that what you're saying?
No, you did explain. I didn't get the point.
Okay, so like I said, okay, so we have two types of focal seizures, basically. We have the simple partial or simple focal, and then we have the complex partial or complex focal. Let me use that word. So basically, in this particular simple focal here, the primary thing you need to know here is that the patient the consciousness is intact. So the patient is conscious. Let me use that word. Okay, the patient doesn't lose consciousness. So when the patient has a seizure, he's aware of his surrounding environment. So there's consciousness, right? That's for.
Yes.
But for the complex partial, so basically it presents in two ways. It initially starts as a simple seizure where the patient is aware that, is aware of his surrounding environment, and then it now transcends into a situation where the patient is no longer aware. So the patient might have maybe jerky movements of the hand, and then the patient is aware that, is aware of his environment. If you call the patient is aware. But for the complex partial, the patient has that seizure, right? Patient has that seizure. Initially starts as a simple seizure or a focal seizure. And then as time goes by, there's secondary generalization and loss of consciousness. So it can start maybe in the left limb and the patient is aware, right? Over time, so let's say this is the left limb, right? And then over time, it now involves maybe the second limb, now involves two limbs, and maybe the patient now loses consciousness. So you are trying to call the patient is not responding, you are touching the patient, you are calling him, the patient is not responding. So something that started as an initial focal seizure has now become more generalized and now involves loss of consciousness. In that case, what the patient has is complex partial. So it's complex partial. So it might start from the temporal lobe, for example, and spread to involve maybe the frontal lobe. And you know that the frontal lobe is the seat of consciousness for us. It's one of the seat of consciousness for us. So I'm just using that as an example, basically, right? Starts from the medial lobe and then spreads to the temporal lobe with loss of consciousness. So the patient might be jerking his left limb, and then all of a sudden you now see him gradually, involving all limbs. And then when you call the patient is not able to respond to you. In that kind of situation, what you have is no longer a simple partial seizure. What you have is a complex partial seizure. That was also I was trying to explain. I don't know if that's clear. Okay.
Okay,
Yeah.
thank you.
Yeah. Okay. So do you have any questions about seizures before we go to the next topic? I'm trying to see how we can finish neurology as soon as possible because we still have ENT and ophthalmology. So I'm just trying to discuss the high topics that you guys need to know for the exams. Okay. Dr. Aksa, can you talk to me? You said you just have an absent seizure. Okay, so can you describe the event? Okay. So can you describe the events basically so that I can help you? Maybe I can, maybe bring you back to consciousness. Okay, so you went totally blank. Okay. So you have to tell me where are you lost so that I can clarify. Dr. Aksa? Okay, the focal seizure. You don't understand the focal seizure. Okay, so let me, I think a diagram would help basically. A diagram would help you guys to understand what I'm trying to say, okay? So let me use a diagram to explain what I'm trying to say. So, let's see. So let me just use a diagram to illustrate what I'm trying to say, guys. Okay, so this is what I'm trying to say here. Okay. So basically what I'm trying to say here is that you have a focal seizure for a patient, right? This is a focal seizure. And then the first thing you ask yourself is when you see a patient who has a focal seizure, it means that it's a particular part of the brain that's been affected. So let me draw that out for you guys so you can see what I'm talking about. So a focal seizure basically is affecting just a region of the brain. So it can be any lobe, it can be any region, it can be any lobe, just a particular lobe. It's not affecting the whole brain, right? So I drew this as an example. I use this as an example to show and illustrate what I was trying to say. So right, this is the brain, right? Right. So when you have, first of all, you need to try and explain what a seizure is. I said a seizure is a synchronized, it's an event, it's a neurological event. That's the first thing. It's a neurological event. It's a neurological event that is characterized by synchronized, high frequency neural firing. So it's like the brain is going overhaul. It's sending a lot of signals. Yeah. And that signal originates, when that signal originates from one part of the brain, it is called focal. So basically, a seizure that has its origin from a particular region of the brain is a focal seizure. Okay. But if that high, that synchronized high firing or high frequency neuronal activity originates from every part of the brain, it's called generalized. Okay, so you can see the first thing you need to know is the difference. For focal, it is localized, just a particular region is firing out. So a particular region is firing out, just one particular region is sending signals, it's just going haywire, basically. It's just going haywire. One particular region is just going haywire, just sending out crazy signals, right? And okay, so for a focal seizure, basically, there are two types. That's the first thing you need to know, right? There are two things that happen here, right? Basically. And the first thing is that we have the simple. What does it mean? From the word simple, it's basically telling you that, oh, it's just a simple, highly synchronized neuronal firing that is occurring from one part of the brain, right? The patient doesn't have loss of consciousness. So the high firing signals that the brain is sending out does not lead to loss of consciousness, right? And this can last for, like, let's say 5, sometimes 2 to 5 minutes, depending. So a focal seizure can last like 2 to 5 minutes. These 2 to 5 minutes, the brain is just sending out crazy signals out. The patient can either be smacking his teeth, or can be having weird movements, can be having abnormal posture, can be having abnormal responses to things, can be irritable. So basically, anything can present as a focal seizure. It can just be a blinking of the eyes, it can just be twitching of the fingers. This can present as seizures, especially focal seizures, right? And now what you need to know is that the most common part of the brain that's usually affected with focal seizures is the medial temporal lobe. Yeah. Medial temporal lobe. So these are the high yield things you need to know, right? Medial temporal lobe. Okay. I don't know if that's clear. Okay, so great. So let's continue. Now that we're already making progress, let's try and understand it further. Now, I went on to say that, okay, now we have the simple focal, which is what I just explained to you. It's just a brief episode localized to a certain region of the brain. There's no loss of consciousness. But what happens in complex partial? So what happens in complex partial? That is CP. So complex partial is also a type of focal seizure. But the difference here is that the seizure might start from, let's say, the temporal lobe, and then it might spread to other regions of the brain. Let's say the parietal lobe, basically. Okay, patient might have, the haywire, the fact that the brain is firing so well, that it can transmit that abnormal signals to the parietal lobe. If it does that, it means that the signal, the seizure has spread to that part of the brain. Okay. Now, what happens in complex partial is that it initially starts as a simple episode, and then maybe the patient is just twitching his hand, just twitching his eye, or blinking one eye. And then when it involves all the limbs or involves every part of the brain, it becomes complex partial. So there's what we call secondary generalization. So it started simple and now involves almost every part of the brain. Secondary generalization, okay? So let me just write this. Secondary generalization, basically. And then here in this particular situation, the patient loses consciousness because, of course, it starts simple, but it spreads everywhere, goes to every part of the brain, both the part of the brain that's responsible for consciousness, right? The seat of awakeness, which is the RAS, the reticular activating system, right, in the pons. So it spreads everywhere in the brain. So it starts simple as a simple eye twitch, and then it now radiates to every part of the body. The patient now goes into full-blown haywire, basically, neuronal haywire. Every part of the brain is affected. And if that happens, what you have is a complex partial seizure, not a focal seizure, right? As against a generalized seizure, basically, every part of the brain is affected. It doesn't start from a small region. It starts everywhere. The whole part of the brain just goes haywire. And then the patient immediately presents with loss of consciousness while going through that phase, right? And in generalized seizures, basically, the patient presents with other features. It could be eye rolling, it could be lip smacking, can be urinary incontinence because of the fact that every part of the brain is affected, right? But in the focal seizure, the patient is able to control those things because the patient is conscious and it's only one particular part of the brain that is affected. I don't know if this is able to clarify a lot of the things that, Okay, great. Yeah. So do you have any more questions? I think those are the high yielding. I think the most high yield part of this particular topic is actually the medications. We'll get to the medications. Okay. So are there any questions, Dr. Aksa, Dr. Jamil, Dr. Lucaria? Do you have any questions? Because I want to move to the next topic almost immediately now.
No, sir. Thank you.
All right. So the next thing we're going to move on to basically is headaches. This is another very simple topic. I don't think we should waste so much time here. So can anybody tell me how do we classify headaches basically? There are two types. There are two ways we classify headaches. Headaches are classified into two ways. Can anybody tell me? So we have headaches.
Unilateral and bilateral.
Okay, that's one way to classify it. That's according to the location, right? But
Also
there's another way.
primary, secondary
Beautiful.
form of this house.
Beautiful. Primary and secondary. So what causes a headache? An headache is just an irritation of basically the intracranial and or extracranial structures. Irritation of the extracranial structures or intracranial structures. Okay, so when there's an irritation of the extracranial or intracranial structure, it leads to pain, right? I want you guys to understand that the brain itself, the neurons themselves, they don't feel pain, right? They might to a certain level, but they don't feel pain like every other region of the body. They do, but not in a direct way. It's not like I pinch you right now. If I pinch you on your skin right now, you will feel pain almost immediately. The neural tissues don't respond to that. And in the brain, one of the things that mediates pain in the brain is substance P. Right? Substance P is one of the major this is one of the major mediators of pain in the brain, right? And this is very important in the pathophysiology of headaches, most importantly, the migraine headaches, okay? So, why is it called primary headaches? It's called primary headaches because there are no known cause. No known cause. No known cause, right? There are no known causes of primary headaches. But for secondary causes, you can have a lot of things. You can have hypoglycemia, you can have different things, right? You can have different things that can cause headaches, secondary headaches, hypoglycemia, you can have trauma, you can have infection, you can have bleeding. These are secondary causes of headaches. So there's a known cause for the secondary headaches. But for the primary headaches, there are no known causes of the headaches. And basically, so can anybody tell me the three types of primary headaches that we have?
I think tension, migraine, and cluster.
Yeah, great. So Yeah, so great. So we have tension, we have cluster, we have migraine, right? So now we'll talk about each of them, right? Let's start with the tension headache. I usually call this a naked headache. Naked headache. That's how I remember it. So it has no associations whatsoever. No associations. That's why I call it naked headache. So you see the patient comes to you, oh doctor, I'm having a headache. The patient does not have any aura, does not have any vomiting, does not have any nausea, does not have any lacrimation, does not have anything at all. The headache is completely naked. I call it tension headache. Tension headache. The patient does not have any features or associations at all, right? But how do we characterize the tension headache? So a tension headache is basically one of the first thing about a tension headache is that it lasts less than 30 minutes, less than 30 minutes to an hour, basically, right? And then the patients usually describe it like a vase, like a band of vase, band, like a band around their head. You know how you tie like a band around your head, like you're trying to, like tie something around your head. Basically, they describe it like a pressure that goes round the head, like it goes round the head. So basically, they describe a tension headache as like a vase-like type of headache, a band-like type of headache, right? And I said that it has no associations. So anytime you think of the tension headache, just think of it as a naked headache. Has no associations whatsoever. Okay? And then lasts roughly less than an hour, and then it goes. Usually triggered by stress. So you're having a very busy day. You didn't have a lot of sleep. You're really, really stressed. When you're preparing for the exams, the step one exams, and you're doing a marathon reading, or you're trying to read for so long, you tend to come down with a tension headache, which is like the most simplest form of headaches, basically. And then because they are so simple and they have no association, it means that they're very easy to treat, right? So you tell the patient, oh, okay, the first thing you need to do is to get analgesia. You can tell the patient to get acetaminophen, let's call it ACM, right? Or you can give the patient paracetamol, PCM, right? Or you can give the patient in very worse, very, very bad scenarios. Like if it's that severe, then you can prescribe an NSAID. If it's very, very severe, and which is most unlikely, it's not usually that severe, right? So you give an NSAID. Another thing that is very helpful for the patient is relaxation therapy, or some people call them behavioral lifestyle changes, basically. But relaxation therapy is also very helpful for them, right? So relaxation, right? Relaxation. So relaxation therapy, right? Right. So relaxation therapy is another thing that is very helpful for them. So apart from using the pharmacological ways of treating tension headaches, such as giving PCM or giving acetaminophen, you can tell them about behavioral or relaxation techniques, telling them to take more rest, to take more breaks. They're doing things, to rest more. Those are the things that help them to take care of the tension headaches. Now, this is in comparison to the migraine. The migraine is like one of the worst types of headaches that you can have. And the most easy way to remember it is pound, right? This is a very common mnemonic. I don't really need to talk so much about it, right? So it's pulsating. It lasts for a day or two. It's unilateral. Most times it's unilateral. You can also have situations where migraine can be bilateral. The patient has nausea, which is the associated symptoms, okay? And then the patient might have, it's usually very disabling. But one of the characteristic features of a migraine headache is the aura, right? Now, the pathophysiology of an aura is usually as a result of increased serotonin, basically, increased serotonin release. So serotonin is a drug that plays a very significant role in the pathophysiology of migraines, basically. Okay. So during auras, there are increase of which causes vasoconstriction, basically, right? But during the migraine attacks proper, there's actually decreased level of serotonin during migraine attacks, and thus that leads to vasodilation. Of course, vasodilation is one of the key major components of an inflammatory reaction, right? I know you guys are aware of this, right? One of the key features of inflammatory reaction is vasodilation. Vasodilation is usually very key. So serotonin is one of those hormones or chemical mediators of migraine, okay, along with substance P and a chemical known as CGRP. Can anybody tell me the meaning of CGRP?
Calcitonin related gene peptide.
Yeah. So calcitonin related gene peptide. So that means I spelled this wrongly then. So now I've listed things here.
No,
some
you are
chemicals.
right. You are right, sir. You are right.
I was right. I was right.
Yeah, you
I knew
were.
I was
Yeah,
right. Okay, so let's
yeah.
just clean
It's
this.
calcitonin gene related peptide.
I remember. So this is the correct thing. So there are three mediators of migraine. 1, 2, 3. So serotonin, CGRMP, substance P. Of course, it means that if you are going to give pharmacotherapy, you are going to be targeting these substances. Very high yield. You need to know this, and this, right? Now, a very key thing about migraine, like I said, is that these associations. So the patient usually has an aura that can be in the form of phonophobia. The patient can be having, can be scared of loud sounds, loud noise, bright lights. These are things that are very common associations of migraine headaches. Okay, and then the patient can have nausea and vomiting, which are very strong associations. Now, because it's a very severe type of headache, we have to be able to treat it acutely and also try to prevent it. That's one of the beauties of migraine. Okay, and so there's a mnemonic I developed for the acute treatment of migraine. So acute treatment of migraine. And the mnemonic is called BATS. So BATS. So it's called B. This is for the prophylactic treatment, right? Prophylactic. So this is preventatory treatment. I'm going to come to acute. I'm going to come to acute now. But let me just tell you guys about this mnemonic before I forget it. I just remembered it now. So to prevent. So this B basically stands for the botulinum toxin. That's the first one. You can use botulinum toxin, right? Botulinum toxin. It also stands for beta blockers. So beta blockers can also be used. Okay, beta blockers. Right? So the B, if you want to prevent migraine, recurrent attacks of migraine, these are the drugs you're going to use basically. The first one is the B. The B stands for botulinum toxin and beta blockers. And then the A stands for amitriptyline. Right? Amitriptyline. So you guys should. Amitriptyline. Now, I told you guys about this particular chemical, right? Now, it's also another target for pharmacotherapy. And then there are antibodies that we use against this chemical, right? Or this mediator. And these antibodies, you can also use them as A. So anti-CGRMP as the second A here. The last T is topiramate, which is an anticonvulsant. So anytime you remember how to prevent migraine headaches, you should remember the BAT basically. But the most commonly tested examples or the most commonly tested drugs that are used in the prevention of migraine is the beta blockers, amitriptyline, and topiramate. These are the three common ones. The other ones are just addendums. Okay. Now, if we want to handle an acute case of migraine, right? There are drugs that we use. They are very, very important drugs that you must know, right? The first drug that we use are NSAIDs. NSAIDs are very, very useful here. NSAIDs, right? If NSAIDs don't work, the next drugs that we use are the triptans. But I want you to understand that the triptans are the first line. The triptans are the first line drugs. They are the first, or rather, should I say they are the most effective? I would say NSAIDs are the first line, then triptans are the most effective. Does anybody know in certain conditions that we don't give triptans? There are certain contraindications to using triptans. Does anybody know them? There are two common ones.
I think coronary artery disease, that is caused by suspect.
Earth what's up, Audie?
Yeah, so ischemic heart disease, ischemic heart disease. What about, what's the other one?
Prince
What's the
metal
other?
also, I think.
Beautiful, presmantial angina. Yeah, so we don't do that. Also, some authorities also say that hypertension, you don't give it to patients with hypertension, right? So they can put it in a question. They can tell you a patient who had presented with an acute migraine attack, and they will put it in the question that the patient suffered or is currently on treatment for chronic stable angina. And they ask you, which drug would you give this patient to, or which drug would you not want to give this patient in treating his acute attack? So you need to know that triptans is the answer to that question. Triptans, okay? Then other drugs you can use are antiemetics, metoclopramide, chlorpromazine. These are drugs that you can also use to manage migraine. So far, so good. Are we clear here? Or is there any part you want me to clarify? Yes, uncontrolled hypertension. Yeah, thank you. Yeah, okay. So let me
Please,
go.
can you
Yeah.
repeat the? No, we don't give triptan during angina, Prince metal, and what? I didn't get it, please.
Yeah, so we don't give the drug in 3 conditions basically. So we don't give it in patients with ischemic heart disease. We don't give it in presmental angina. Of course, presmental angina is, it's the vasospastic angina, right? There's a vasospasm of the coronary artery. Yeah. And then we don't give it in uncontrolled hypertension. So a patient that has a very uncontrolled hypertension, the patient is hypertensive basically, we don't give triptans to them. So they might put it in the question, any of these contraindications, and they just want you to know if you know the contraindications to triptan. So the question might come in the form of, oh, the patient has migraine, but the patient has ischemic heart disease. They're not asking you which drug would you not want to give the patient in order to take care to abort the acute migraine attack. So in that kind of situation, you want to go for the triptans. That's what I'm trying to say.
Yeah, thank you.
Yeah, okay. Okay, so okay. So someone said I should repeat the pound mnemonics. Okay, so the P stands for pulsatile, the O stands for 1 day, the U stands for unilateral, the N stands for nausea and vomiting, and then the D stands for disabling. Okay. The last of the headaches we're going to treat is the cluster headache. By the way, I wanted to explain something again, that migraine headaches and tension headaches are more common in females. So when you're looking at the question, it doesn't mean that migraine headaches and tension headaches don't occur in males, but there is a higher incidence of these headaches in females. So I want you guys to take note of that, okay? Now, cluster headaches is the opposite, right? Cluster headaches is the opposite. So cluster.
Sorry, quick one. You said the pound was pulsatile, 1 day, and then the last one was disabling. I didn't get the U and N. What does that mean?
The U means unilateral, so it occurs most times unilaterally. It doesn't mean that it doesn't occur bilaterally. I'm just trying to say in most instances. Yeah, primarily unilateral. And then the N stands for nausea and vomiting, which is the associated symptoms.
Gotcha. Thank you.
Okay. Yeah, okay.
So what does it mean, disabling?
Disabling means that when you have disabling means that the headache is so severe that it doesn't allow you to go about your daily activities. For example, if you're a doctor, you'll be able to treat your patients properly. If you're an engineer, you'll not be able to go to work. It actually literally grounds you.
Yeah.
I myself, I actually suffer from migraine a lot. Yeah, so it can be quite disabling. It can be
Yeah,
very, very
I
disabling.
understand.
Yeah. So so Dr. Nafia talked about the dihydroergotamine, which acts on the serotonin. Yes, that is actually correct. I didn't want to talk about that because these drugs, they're not really as high yield as the ones that I mentioned. That's why I didn't really breed them so much. But yes, there are drugs that exist like that. There are drugs that the dihydroergotamine drugs are drugs that we can also use in acute, not abortive phase of migraine. In acute cases, we can use these drugs, but we can't use them for preventive, right? So yeah, thank you, Dr. Nafia. Okay, so let's move to cluster. I'll try and be fast here so that we can. So cluster, basically, let's just do a quick one about cluster. Cluster is found in males predominantly, right? A higher incidence in males, and it has its own associated symptoms. These associated symptoms is what you must know. This is the symptom that helps you to identify it, basically. Associated symptoms, right? So the patient presents with symptoms that are similar to Horner syndrome. Let me use that word. So the patient presents with lacrimation, right? Lacrimation. The patient presents with rhinorrhea. The patient also presents with a kind of like retroorbital pain. So now the reason why it's called clusters is because it comes in, how will I put it, it comes in clusters, and it lasts usually there are a lot of multiple episodes of cluster headaches because of its short duration. So usually it lasts about 15 minutes. That's how long it lasts for an episode. 15 minutes to about an hour, basically. It's not as disabling as migraine, right? In some cases, you can also have features of Horner syndrome, which I mentioned. The patient can have meiosis, the patient can have ptosis. There was a question I saw in an MBME that they talked about, that the patient presented with features that were suggestive of cluster headaches, and they now asked what additional symptoms would the patient have. And the answer they chose was ipsilateral ptosis. So you should know this. That's why I'm saying it. I've seen it in an MBME, okay? And so cluster headaches tend to be brief. They occur at a particular time in a day. So they can occur maybe in every afternoon for some patients, and sometimes they can occur maybe every evening on the same, like every day. So today they might occur in the evening, tomorrow they occur in that same evening, next tomorrow they occur that same evening. So that's how cluster headaches present, basically. That particular time of the day is when they usually present most times, okay? So how do we treat it, basically? What's the treatment? So very unconventional treatment is oxygen, right? Oxygen, and then you can use, in rare instances, NSAIDs. So the first line is actually oxygen. Then the second line is NSAIDs, right? Now, there is a very important drug you must know here, and it's for prophylaxis. So let's just put PX. It's verapamil. You must know this drug. It is high yield. It is very, very high yield. It's a calcium channel blocker, right? Very, very high yield. You use it to prevent future attacks of cluster headaches. You use the drug to prevent future attacks of cluster headaches. Some people might say you even use some cases you can even use triptans for the acute attacks in some cases, but of course, NSAIDs and oxygen are like the first and second line drugs. But verapamil is a high yield drug that you must know. It's a calcium channel blocker that is used as prophylaxis for patients with cluster headaches. Okay. And then so far here, do we have any questions about this? Do you have any questions? Not really. Not all of them are due to vasoconstriction. Not all of them are due to vasoconstriction. The one that has a documented evidence as of vasoconstriction being the cause is actually migraine. That is the one that we have a documented evidence that vasoconstriction plays a significant role in the pathophysiology. But for the others, it's not. It doesn't. It's not really a main. Vasoconstriction does not really play any role in them. Basically, tension and cluster doesn't really play a role. Migraine is the only headache that there has been um, a documented evidence that vasoconstriction plays a role. Okay. Yeah. So for my own headache, where I come from, my own country, Nigeria here, the common drug we use for prophylactic therapy for migraine is actually amitriptyline. We don't use beta blockers. Amitriptyline is a common drug we use here, especially where I stay here in Nigeria. It's amitriptyline is the common drug that we use, right? That's just by the way. Okay, so let's go to the next drug. Next thing we're going to talk about is trigeminal neuralgia. This is very high yield. This is very, very high yield. What is the
Sorry,
etiology? Yeah,
please,
go
I
on.
need to clarify. This amitriptyline for cluster headache or migraine.
No, it's for migraine. It's for migraine. I said me. I suffer from it, and that's what I use. That's what was prescribed to me by my neurologist, right? So I'm just talking about for prophylactic therapy. Amitriptyline is used for migraine, not cluster, please.
Prophylaxis.
Yeah, prophylaxis. You know, it's part of the BAT. I talked about a BAT. I don't know if you're aware for migraine.
Mm.
The BAT. Where I said here's
Yes,
beta blocker, here's amitriptyline, here's
I
tropias.
missed that part. That's how I was
Yeah,
Yes,
yes.
beta blocker, and then amitriptyline and topiramate.
Yes, topiramate. Beta blocker, amitriptyline, topiramate. So you can just remember BAT. Beta blockers, amitriptyline, yeah, and then topiramate. Topiramate is an anticonvulsant. So anytime you're stuck in the exam, and you don't know what drug you can use for preventing migraine, just remember the BAT. Once you remember the BAT, you're covered. Okay.
Thank you.
Now, yeah. So trigeminal neuralgia. What is the cause of trigeminal neuralgia? So trigeminal neuralgia is like, how do I explain it now? It's a situation. It's a kind of, when I say it's an extension, it's like the worst form of cluster headache. Let me use that word. It's like the worst form of cluster headache, right? It's like the worst form of cluster headache. Let me just put it in that way. Sorry to say. So basically, there's this intense sharp. It's usually sharp. The patient describes it as sharp, intense, sharp, unilateral, recurrent pain, and it gets its name trigeminal neuralgia from the fact that the cranial nerve that is mostly implicated is cranial nerve 5. This is a very high yield question that you must know. Cranial nerve 5. So the part of the face, you know, the sensory innervation to the face basically is by the trigeminal nerve, right? This is the face. So V1 supplies here, V2 supplies this region, and then V3 supplies here. So let me write this. Right. And V1. Right. So this particular nerve is the one that is implicated in trigeminal neuralgia. So basically, ordinarily, when you touch your face, you're not supposed to feel pain. When you touch your face or touch your jaw, you're not supposed to feel pain. But patients with trigeminal neuralgia, any slight touch or tactile stimulus to the face will cause a very sharp pain that will go along the branches of these trigeminal nerves, right? And what we do understand about this particular disease condition is that it's actually caused by, when I say aberrant, let's say a loop of blood vessel. So let me draw this so that you can understand. So this is the trigeminal nerve. Let me draw it for you. Let me show you what happens here. This is the trigeminal nerve. You need to know that trigeminal nerve is the largest cranial nerve. This is the largest cranial nerve. It's the largest cranial nerve. Okay, you need to know that. So what happens here? There's a loop of blood vessel that is formed around the trigeminal nerve, right? A loop of blood vessel forms around the trigeminal nerve. And this loop of blood vessels, when it vasodilates, it compresses these trigeminal nerves. It causes compression of this trigeminal nerve. And that leads to that abnormal firing. Abnormal firing of the cranial nerve. So usually in the first aid, they will tell you that it's an aberrant loop. Aberrant means it's not something that's supposed to be there. It's more like, not a malformation per se, but it's not supposed to be there. That loop of blood vessel is not supposed to be around the trigeminal nerve, right? But in some selected individuals or in some patients, there's an existence of this loop of blood vessels around the trigeminal nerve. And when the vasodilate, they cause compression of the trigeminal nerve, and that leads to the trigeminal neuralgia that the patient experiences. And for some very weird reasons, this drug, carbamazepine, seems to be a drug of choice. Carbamazepine that we use for, it's an anti-epileptic drug. It's a drug that we tend to use to treat patients with trigeminal neuralgia. I don't know the pathophysiology, I don't know the pharmacology behind that, but I've never really asked myself why. I just read it when I was playing for my exam. I just read it and understood it to be the drug of choice for trigeminal neuralgia. Okay, do we have any questions there before we move to the next topic? Any questions? Okay. So the next topic we're going to move to basically are the movement disorders. Movement disorders, basically. Okay, someone has a question. Okay, I should explain one more time. Okay. So let me go over it again. So basically, trigeminal neuralgia is a situation where a patient has this intense, sharp, recurrent pain, right? And this pain is along the face. It's on the face. Why is it on the face? Because the trigeminal nerve sends sensory impulses to the face, or rather receives sensory impulses from the face, right? And so the patient has this intense, recurrent, sharp pain when the patient has tactile stimuli. Tactile stimuli means touch the face. It could be brush, it could be spoon, it could be anything, right? Immediately you touch the patient on the face, the patient has this sharp pain that goes along the tract of the trigeminal nerve, right? And then this patient has it recurrently. It's not everybody that has it, right? It's not everybody that has trigeminal neuralgia. It's some selected persons. And I was trying to explain that the pathophysiology behind why this patient has this sharp pain is because the trigeminal nerve, as it's going down or coming to supply the face, there's an aberrant. What do I mean by aberrant? Meaning that it's not supposed to be there. Meaning it's not supposed to be there. It's an abnormality, basically. There's an abnormal loop of blood vessels around the nerve. So this is the aberrant loop. So it's more like a loop of blood vessels around the trigeminal nerve, usually an artery. And this nerve vasodilates, right? Vasodilates usually. And when it vasodilates, it causes compression of the trigeminal nerve. That compression of the trigeminal nerve amplifies, how will I put it now? It amplifies or overfires. So ordinarily, that pain that you touch the patient's face is not supposed to, that touch you touch the patient's face is not supposed to cause so much pain. But because there's overfiring of this trigeminal nerve due to this compression of this compression by this aberrant loop of blood vessels, it sends very, very sharp signals to the brain. So this loop is the pathophysiology. This aberrant loop around the trigeminal nerve is what causes the abnormal firing of signals, pain signals along the trigeminal nerve. And that's why when you touch the face, it sends very haywire signals. Let me use that word if there's anything like that. Okay. And how we treat trigeminal neuralgia is by using this drug called carbamazepine, basically. Okay. I don't know if that is clear. Okay. So yeah. So let's continue. I was going to talk about movement disorders. That's what I'm going to next. Do we have any question? Am I too fast, or I don't know? Am I too fast, guys? Yeah, okay.
No, yeah.
Am I too fast? Okay.
No, you're
No,
not.
you are doing good.
Okay, great. So Dr. BN wrote V1 is involved in cluster and V2 and V3 are mainly involved in trigeminal neuralgia. Okay, that's AI. Well, I didn't know that, but thank you, Dr. BN. I didn't know that though. Thank you, Dr. BN. Okay, so let's continue. The next thing we're going to talk about is movement disorders. Okay, movement disorders. Okay, so there are certain movements that we need to know that are very high yield for the exam. First aid gives you this list of very long, what do I call it? Yeah, first aid gives you this list of very, very long movement disorders that you need to know. But I can tell you for a fact that you need to know just a few of them. You don't need to know all of them, basically. But what is even more important about knowing this is that knowing the lesions that these particular movement disorders, knowing the particular part of the brain that's affected in these disorders is what is most important. But before I dive into that, I would like to talk about tremors first, because tremors are very high yield in the exams. Okay, so let me talk about tremors first. Okay, so we have essential tremors, we have intentional tremors, and then we have resting tremors. Okay, so basically, essential tremors, what you need to know about it, the first thing you need to know is that it's familiar. That's the high yield stuff about it, right? And usually, patients with intention tremors, essential tremors, basically, are usually old patients, usually at the age of 50 and above, right? And one particular thing that is very high yield is that the amplitude of the tremor or the frequency of the tremor is reduced by alcohol. This is what you need to know for the exam, basically. I'm just telling you what you need to know out of the exam. You can go for your MBMs, do your MBMs, you see this, right? Alcohol reduces it. I don't know how it does that, basically. I've never really bothered asking. But all I know is that this is very high yield. This particular information is very high yield, right? And then how do you treat essential tremors? You treat essential tremors basically with two drugs. Use a beta blocker and then use a barbiturate called primidone. This right here is what you need to pass the exams. This right here. You don't need any other stuff as concerning essential tremors, basically. This is what you need to know for step one. You don't need to know any other extra stuff, basically, right? For intentional tremors, you need to know when does the patient have intentional tremors? When does it occur, right? So the patient starts having essential tremor when the patient tries to reach out for an object. So the patient has when the patient assumes a sustained posture, the patient has essential tremor. So when the patient reaches out for a cup, let's say this is a cup, for example, now, right? The patient starts having vibratory motions or tremors. And of course, this is relieved by rest. Which part of the brain is affected? Cerebellar dysfunctions. This is what you need to know, right? Cerebellar dysfunction. Very easy. This is what you need to know for the exams. Not a lot of stuff over here. Of course, resting tremor is the one that the patient has, what do you call it? The patient's hand is at rest and the patient has tremors at rest. And of course, I'm sure that everybody knows the condition that you find resting tremors. Another thing you need to know about resting tremors is that they tend to be asymmetrical. This is also very high yield. So by knowing the limb that's affected, if they tell you the patient has the resting tremors has tremors in both limbs, and the patient's really forefather had that type of tremor. So you'll be thinking of essential. So essential is a symmetric type of tremor. Symmetric tends to affect both limbs, both upper extremities, right? While resting tends to be asymmetric, right? And then, of course, this is more common in Parkinson's disease. These are the high yield things you need to know for the exam. Not a lot of stories here, straight to the point. You get what you need to get, and basically that's it, right? Now, I'm going to ask you guys the questions, and you guys are going to tell me where do you think this condition is most likely found, right? Dysarthrial tremor. But among all of these right now, the ones you need to know, for example, so you have a question? Is there a question?
Yes, please. Can you repeat what you said about intentional tremor?
Okay. So I said that intentional tremors, right? Intentional tremors are very simple. You can see that this guy wants to reach out for a cup here. This is a cup. He has his glass of beer or Coke or something. And as this patient is reaching out for this glass of cup, he starts having these tremors, vibratory movements of his distal digits, right? As he's trying to reach out for this cup. Now, this type of tremor where the patient has a sustained posture, you can see that this hand is straightened. So the posture here is sustained, right? He's trying to reach out for a cup. This type of tremor that occurs is known as intentional tremor, right? It's intentional tremor. This type of tremor where the patient wants to carry out an act, right? He wants to do something, right? But the patient starts having a tremor when he wants to do that thing or he wants to reach out something. So you want to give maybe your son a pen or your friend a pen, and you want to collect it from the patient or your son. You notice that your hand starts shaking. That is intentional tremor. And
I have
usually,
a question, doctor.
yeah, go ahead.
No, it's okay. I was saying that if they say intentional, so can it be controlled?
I've never really
Because
asked myself.
the name says intentional.
No,
I don't know.
I think the only way you can control it is if you're at rest, if you don't do anything. I don't think you can control it basically.
Yes,
I think the
yes.
trick,
If you want to control that, don't take the subject or the object at once, At resting, it will be controlled.
yeah. So basically, if you rest, you will not experience the tremor. So the way to control it is by resting the hand. Yeah, that's the way you can control it.
Well, I think if I may chip in, when you say intention, a person has an intention of doing something, maybe has intention of picking up his cup of beer, then his hand starts shaking.
Yeah. Yeah. So I don't know if that makes sense. Okay. Okay, so somebody's talked about sustained posture. Okay, yes. I was trying to figure that out. Yes. So sustained posture is with what do you call it? Essential tremor. Sorry, I mixed that up. Sorry. So sustained posture, the patient with sustained posture, outstretched hand, yes. But intentional tremor is different because basically the patient is trying to reach out for something, is trying to extend and get something, which is what I just drew here. The patient is trying to reach out to his peer, then he starts having the tremor. That's essential. That's intentional tremor. But essential tremor is quite the opposite, right? It's usually symmetrical, meaning that it affects both, can affect both extremities, both the left and the right hand, basically. It's usually familiar and it's usually relieved by alcohol, basically. So these are like the high yield things you need to know. And of course, just like the doctor corrected me, it is it's implicated the patient to sustain posture. That means the patient wants to do out something that would require him to assume a particular posture, right? Sustain posture. Let me just put this here. Okay. Yeah, I think that is basically about tremors because I know that it comes out a lot in the exams. That's why I'm taking my time to explain it. Do we have any questions about tremors? So Dr. Sharon, yes, you are right. It comes under essential tremor. Yeah.
Doctor,
Yeah.
so in the tremors, you told us that is essential tremor, resting,
Yeah.
and intentional tremors.
Yes.
Okay.
Affirmative. Affirmative. You must know their individual characteristics, not just knowing the name, because sometimes they can give you a question, right? And they can tell you, they can give you certain clues, like I mentioned earlier on. For essential tremor, they might give you a history of the fact that maybe the patient's father or maybe great grandfather had that similar type of tremors. Right? That's the first point that you need to know for essential. The second thing you need to know is that they'll tell you that the patient usually, when he takes alcohol or sometimes he rests, the tremor stops. Right? So you need to know that as well. And usually it affects older individuals, usually greater than 50 years, around that age group. Right? And then okay, yeah, and then intentional tremors are tremors that the patient wants to reach out for a glass of beer. He wants to carry out an act, just like Dr. Wonkodi said. The patient wants to carry out an act. He wants to reach out for something, and then the patient starts having this. Yeah, the patient starts. Yeah, the patient starts having that tremor. Yes, so that's intentional. But resting, the patient is just resting, and then he's having his tremor, and that one is commoner in Parkinson's disease. Resting tremor tends to be asymmetrical, tends to be unilateral most times, tends to affect one limb, right? Tends to affect one limb, as against essential tremor that tends to be symmetrical. Okay. Yeah. So the most important movement disorders that we need to know, basically, I'm going to list them, and then we'll talk about every one of them, and then we'll talk about the neurodegenerative conditions to end the day. Okay. So. Okay, so the neurodegenerative disorders that we're going to talk about, or rather, sorry, the movement disorders we're going to talk about, I'm going to talk about each and every one of them, and perhaps you guys will tell me where they are located, right? So the first one I'm going to talk about is dystonia. This is high yield. I'm just going to talk about the high yield ones, and then we'll move on to the next topic quickly. Dystonia. Okay, so dystonia basically is just a sustained involuntary. So it's sustained and it's involuntary. So the patient is not within the patient's control, or the patient is not trying to carry out anything. The patient is just on his own, and then he has this sustained involuntary muscular contraction. Involuntary contractions, right? So you must know this. What conditions do we find dystonia? What's the commonest, basically? So use of what condition do we find it?
Antipsychiatric medication.
Yes, antipsychotic medications, yes. So this one is pretty much straightforward. Psychotic medications, okay? Antipsychotic medications. What about hysteresis? What is hysteresis? Does anybody know what hysteresis is and where we can find it?
Yes.
Yeah, so another
Even having a movement, usually due to liver dysfunction with buildup of ammonia.
Yeah, so good. Yeah, so it's also known as flappy tremors, right? It's a flappy tremor.
Yes.
So the patient, so what happens in hysteresis basically is that the patient stretches his hands out, and there's a brief loss of tone in his hands. So the hands tries to go down, and then he takes it up. So let me draw this basically. So the patient stretches his hands out, his two arms out, right? I'm sorry, guys, my drawing is very bad. My drawing is very bad, I know. So what happens in hysteresis is that you tell the patient to stretch his hands out, right? While he's stretching his hands out, and you tell him to dorsiflex the hands. So he dorsiflex. So dorsiflex means that he points his fingers upward, right? Now, what happens there is that because of the accumulation of byproducts to the brain, such as ammonia and the likes, the patient has a temporary loss of tone. The reason why the patient is able to dorsiflex his hand and sustain it is because there's a tone there. There's a tone here. So the patient briefly loses this tone, and then the hand comes down. These 2 digits comes down. I mean, when the patient understands that he's meant to take the hand back up, it goes back up, but the patient can't sustain that tone, so it comes down, and he does that repeatedly. That down and up movement you are seeing is what causes is why it's called flappy. Let me go over it again. Let me go over it again, right? When you tell a patient to outstretch his hand, right? You tell him to outstretch his hand, and then you tell him to dorsiflex the palm, right? And you tell him to leave it that way. So the patient requires tone to keep the hand in that position. But what happens in hysteresis is that there's a repeated loss of tone, a repeated loss of that tone. And so the hand tries to fall, he tries to bring it back up. The hand tries to fall once, he brings it back up. He tries to fall again, he brings it back up. He tries to fall again, he brings it down. So that repeated cycle is what gives it that name, flappy. Right? Like a flap. You know how a flap works? A flap moves front and back, front and back, front and back, basically. So that's what happens in hysteresis. And this is as a result of accumulation of, metabolites. It could be usually hepatic encephalopathy. Hepatic encephalopathy is the commonest cause of flappy tremor. I don't know. I think there's another cause of it. I don't know. Do you guys know another cause? I think uremic encephalopathy causes it.
Yes.
Yeah, and then and then there's carbon. Is it carbon dioxide toxicity? I don't know. You guys should check this out. Yes, hypercapnia. Yes. So those are the things that can cause a flappy tremor, which is hysteresis. The next one we're going to talk about quickly is chorea. Chorea is very important because it's very high yield as well. Chorea. So chorea can be defined as a sustained. So a lot of them are sustained. I don't know why. So a lot of them are sustained. Very funny way of describing movement. So the patient has sustained jerky, purposeless movement. So doesn't have any purpose, right? So this is how you remember it. It's sustained, it's purposeless, and it's jerky, right? What are the conditions that you can find chorea? Can anybody give me an example?
Chorea.
Huntington's disease.
Huntington disease. Yeah.
Rheumatic
Yeah.
Jones criteria, rheumatic disease too.
Yes, rheumatic heart disease, which is Sydenham chorea.
Korea.
Yes, and Huntington's chorea. Yes, those are the two. So those two topics, those two causes are very high yield. You need to know them, and we'll talk about one of them in the neurodegenerative disorders, right? And then the last but not the least we're going to talk about is hemibalismus. So hemibalismus. So what happens in hemibalismus is that the patient has this sudden wailing of his arm. It's like he's not in control of that other part of his arm. So he just swings it abnormally. So he swings the right hand. It could be the right or the left. He swings the right hand or the left hand abnormally. They call it wailing movements, basically. And these are usually involuntary wailing movements. Involuntary wailing movements. Okay. And what condition do we find hemibalismus? Which nuclei is affected in hemibalismus?
Subthalamic.
The amygdala.
Yes.
Subthalamic
No,
nuclei.
sorry.
Amygdala.
No, it's not amygdala. It's not amygdala.
Related to other things, this it's basal ganglion, subthalamic.
Basal ganglion.
Yeah, so the
So the
answer is
basal
subthalamic.
ganglion.
Yeah, so it's
Subthalamic.
actually the subthalamic nucleus. Yes, so let's get that straight so that we can understand it. It's subthalamic, Dr. Margaret. So subthalamic. Let's not forget it, okay?
Yeah, thank you.
Yeah. When we start doing review of CT scans, neuronal image, CTs, I will be able to help you guys identify these regions. I'll leave that for the last class so that we don't waste so much time. It's a very long topic. Okay. So the last part we're going to talk about movement disorder is something that is very, very common in the exam. That, in fact, I think in my own exam it came out, and it is called restless leg syndrome. I'm just going to talk about it and what came out in my own exam, basically. So I'm doing you guys like a recall. So they brought a question about a patient who had restless leg syndrome. And one of the questions they asked me was, what investigation would you want to do for this patient? What's the what investigation would be useful in managing this patient, right? So the first question they wrote was they wrote CT scan. Yes, that's the option A. I remember this question so well because after I came out of the hall, I discussed it with someone. And one of the questions they put there was iron studies, right? And they put the next question they put there was a renal ultrasound scan. And one of the questions, the last option they put there was, I'm coming, you guys should permit me. Let me try and remember. Here, last option they
It
put
was
was EUCR.
slit lamp examination.
Yes. Yeah. So I think this was my question on restless leg syndrome. They asked which investigation would I do alongside this. Yeah. So
Iron.
what do you guys think? Yeah.
Iron.
Iron.
Yeah. Yeah, great. So iron was
Iron.
the answer. Yeah, iron was the answer. But you guys should know that restless leg syndrome is also commoner in patients with kidney disease. It's also very common in patients with CKD and DM. It's also common. But for this question's sake, this particular one that I answered in my exam, the answer was iron studies. Okay. So this patient has this uncontrollable urge to always move his leg. The patient can't stay one place. He always wants to move his leg, basically. That's how they present. And one of the most common causes of restless leg syndrome is iron deficiency anemia, IDA. Right? So iron studies are very important in these patients if you're evaluating them. Okay. In a situation where you do not see iron studies in the exam, you would look for things that will give up CKD and DM. So in a situation where the options doesn't have iron studies, the next investigation you want to do, maybe it's a HB1AC or maybe an EU creatinine or maybe an renal ultrasound scan, something like that. Basically, I'm just trying to say that the first thing you should note in your mind is an iron study. That's the first thing because this is the commonest cause, right? This is the commonest cause, iron deficiency anemia, right? So if there's no iron studies in the option, then you look for either one of these, any investigation that will lead to any of these diagnoses, right? Okay, so do you have any questions about that? Yes, so how do we treat it? Basically? How do we treat it? That's the next question. So how do we treat it, guys? What is the drug of choice for treating restless leg syndrome? Yes, so dopamine agonist. Yes, dopamine agonist.
Dopa.
So what's the second drug that we can use? What drug? Second drug can we use?
Gabapentinoids.
Yes, thank you, doctor. Gabapentinoids. Yes. Okay. So this is high yield. You need to know this too. This treatment, something you must know too. Very high yield.
Supplements as well. Maybe iron supplements as well.
Yes, iron supplements too is another way, but that is down the food chain. So we can put iron supplements. Right. So this is
Sorry,
high yield.
doc.
Yeah.
Is when you say gabapentin, is it different from gabapentin, or they're all the same?
It's the same thing. It's the same class of family. It's the same class of family.
All right, thank you.
Yeah.
And what about the pregabalin? It's also included to gabapentin. Pregabalin.
Pregabalin. I don't know if gabalin. I don't know. Though. I don't know. I won't say what I don't know. Basically, so someone is asking a question. I won't say it's part of it. I won't say pregabalin and gabapentin are the same. But I think that they have the same mechanism of action. I don't know, doc. I don't. I'm not really sure about that. I would have to actually go and research about that, basically.
Because why we ask the question, because sometimes the options, they may not give you dopamine agonists directly, it will give you examples of drugs that are dopamine agonists.
Yeah. So I think the only dopamine agonist that you can use for restless leg syndromes are the ones that end with the null, NOLE.
Hi.
So
Is she there?
so the ropiranol, you know that you use these drugs too for
Is she there?
Parkinson. You use
Oh,
this
wait
one.
for her because you have to sign your papers. Uh-huh.
Please, Dr. Margaret, can we mute, please? Okay, yeah, thank you. So
I'm very sorry.
yeah, no problem. So the roparinol and all the null families are the drugs that we can use for management of restless leg syndrome. So Dr. Askaus, yeah. So I'm sorry. Let me address some questions here. Now, somebody said gabapentinoid are derivatives of GABA. I don't really know. I would have to ask that. I would have to research about that. I wouldn't tell you guys what I don't know, basically. The next one is restless leg syndrome and akathisia similar. I think they are. I'm not really sure about akathisia and restless leg syndrome. But what I can tell you, what I can say about akathisia is that akathisia usually is as a result of um, use of antipsychotic drugs, and I don't think that is the same etiology for restless leg syndrome, right? I don't think it's the same etiology. So in terms of etiology, they are not similar. That's what I can say about these two. But it's almost the same. It's almost the same presentation, but I don't think that they're the same. Okay, but we can always research about that, and you guys can also inform me because I can learn from you guys as well. So roparinol is one of those drugs. Dr. Mukodi, I'm answering the question that you mentioned. The drugs that end with the NOL are the drugs that you use to treat restless leg syndrome. Okay. So in the option, if you see this, you pick it. It's preferable, right? If you don't see this and you see iron, you can pick it. If you don't see iron, you see gabapentin, you can pick it, right? But of course, the question usually directs you to which of the options you are going to pick, right? So if they tell you, oh, if they tell you that the patient is iron deficient, of course, in that case, a dopamine agonist will not help that patient. Iron will be preferable for that patient. Okay. If the patient is not iron deficient, then a dopamine agonist is the best option. I don't know if
Doc,
that's.
thank you.
Yeah. Okay. So I'm going to round the class up with the last thing we're going to talk about, which is movement neurodegenerative disorders, basically. So I'll just talk about the ones that are the most important ones, basically. So neurodegenerative disorders can be classified into three, right? Can be classified into three. Neurodegenerative disorders can be classified into three, right? Come in, guys. Let me just do this quickly so that we can end today on this note, right? Okay, so so that you guys can have your class. So neurodegenerative disorders, NDD, can be classified into three according to the causes. So we can have the vascular causes. We have the genetic causes. And then we have the infective causes. One thing that links all of this is that they tend to present with symptoms that are in keeping with dementia. And dementia simply means a chronic decline in neurocognitive function. So dementia is a decline, a chronic decline, meaning that it's a very long time that this thing has been happening. So a chronic decline in neurocognitive functions, right? And this significantly impairs activities of daily living, right? So classifying this under three, we have causes, different causes, right? But here we have vascular dementia. vascular dementia. So when you see neurodegenerative disorders, these are the things, this is how I want you to classify it in your mind to make it very easy. Then the infective causes that that we know is CJD, Creutzfeldt-Jakob syndrome. And then the other ones that we have are peak disease, Alzheimer's disease. And then the other one that we have here is the Huntington's disease, HD, right? Right? And then we have the Lewy body dementia, This is just a broad classification. We're going to talk about each and every one of them. Very, very important. Let me start with the infectious causes, right? Let me start with the infectious causes. What you need to know about CJD for the exams, basically, is that these patients tend to the pathophysiology. Let me start with that first. Or let me put it this way. Let me make it a lot more easier for you guys. When you're talking about neurodegenerative disorders, after you have classified it in this way, there are three basic questions you need to be able to answer for you to get all the questions on this step. The first thing you have to answer is that you have to know the part of the brain that's affected. The part of the brain that's affected. Part of the brain affected. Especially for all of them, basically. You need to know the part of the brain affected. The next thing you need to know is the symptomology. Symptoms. Right? The next thing you need to know is this cranial CT imaging. And then you need to know the histological, able to recognize the histology. These are the three things that you need to know in order to make sure you get maximum points when answering neurodegenerative disorders, right? Now, and that's how we're going to answer all the questions. That's how I'm going to explain. It's this templates I'm going to use to explain all the neurodegenerative disorders that we have here, right? Now, in starting with Creutzfeldt-Jakob syndrome, right? The first thing you need to know about this is that it's the cortex that is mostly affected. Cortex. That is the part that is mostly affected. The risk factors for having Creutzfeldt-Jakob is usually exposure or a transplant. So you have a patient who has a transplant, maybe a solid organ transplant. It could be a lens. The most common example of transplant that you need to know is lens. That's the lens. In ophthalmology, it's an ophthalmological procedure where the lenses are being transplanted. And then the pathology behind this is that prions are the major proteins that are implicated. So we have normal prions in our body, right? They are normal proteins that are supposed to be degraded by protease. Protease. So every normal proteins that have a alpha helix structure can be degraded by a protease. But when these alpha helix structures take an alternate configuration, they become beta plated. They accumulate, meaning that the beta protease won't be able to cleave it and destroy it. So if it's not able to cleave it and it accumulates in the body, right? So what happens? I've seen this in a U-World question where they put a patient with CJD, and when they put the patient with CJD, they wrote in the option that what happens, or what is the configuration of, what is the protein configurational change that occurs in this patient? So they put this is the hormone. So for a normal patient, PRP is normal prion proteins, right? And it has the S to signify that it is a prion protein, right? So this is what normal proteins with alpha helix structures look like, right? And this is what it is. But when it undergoes the configuration, it now becomes a PRP SC. I've seen this question in a U-World question. I've seen this thing I'm telling you, I've seen it in a U-World question when I was preparing for my exam. And you must know this. So the configuration is that the S becomes an SC, right? So you must know this. I've seen it in a U-World question. I've seen this thing in a U-World question. That's why my brain just went straight to it so that I can tell you guys. But what you need to know for the exam purpose, is the proteins that are implicated. The proteins that are implicated are called prion proteins. Prion proteins. And it's not just any kind of prion proteins. They are abnormal prion proteins, that actually causes this disorder. Okay? And now the next thing we need to ask ourselves is that what is the symptoms? What do these patients present with? The most pathognomonic symptom that you must know for the exam is that these patients present with, first of all, you need to know that this disease condition is almost fatal. In fact, it's 90% fatal. It's 90% fatal. So let me write that there. It's 90% fatal. 90% fatal. 90% fatal. Meaning that these patients, once they have this disease condition, within a year they are dead. Within a year they are dead. It's almost always fatal. And then these patients present with what we call a myoclonus. A myoclonus. MC. Where when you reach out to them, you try to reach out to them. Maybe for example, they are talking to their friends, and you just come behind them, you sneak behind them, and you startle them. They start having this sustained jerky movement, right? They start having this sustained jerky movement for a very, very long time. You come behind them. Let's say somebody wants to surprise you and tell you, "Oh, I got you this person," just sneaks behind you. For patients with CJD, they tend to have this myoclonus if you do that. So that's how you remember it. You try to surprise them, they start having myoclonus, right? Other symptoms they have, dementia is actually a very, very late finding. In fact, when they get to the stage where they are demented, that is almost 100% fatality rate at that point, right? They also present neurocognitive declines. They are not able to carry out their executive functions, and all that. Currently, it has no treatment. It has no treatment, basically. So most times when patients have it, they tend to not survive. What you will see on imaging, on the CT imaging, is the patient's brain will have what we call spongiform cortex. So let me show you guys what that means. So let me show you guys what that means so that we can see. I'm coming. Let me just show you guys what that means. Coming, yeah. So I'm trying to show you guys. So this is what I'm trying to tell you on histology, right? You can see this. The word spongiform means there's a vacuolization. So there's vacuolization here, these white spaces you're seeing here. But there's no surrounding inflammation, meaning that I told you one of the markers of inflammation, one of the markers you need to see on inflammation is fibrosis. One thing that you would see when a patient has inflammation is fibrosis. It's very, very common on histology slide. And one of the ways you'll be able to recognize fibrosis on histology is that it's usually pink. It's not blue, right? It's usually very, very pink. Anytime you see an histology slide and you want to know if that slide or that tissue is undergoing an inflammatory process, you usually see the background being very pink, not blue. That pink represents sclerosis, massive deposition of proteins, basically, right? So here, this patient is having vacuolization. This vacuolization is what we call spongiform. So it looks like a sponge. You can see that a sponge has hole. I don't know how many, when you're washing your dishes at home, you see the sponge you use has or what will I use as an example now? I don't know if you guys watch this cartoon, SpongeBob SquarePants. I don't know if you guys watch this cartoon. So that just the way SpongeBob is, when you do histology, that is exactly what you see on histology, right? That's exactly what you see on histology. Let me go back to what I was trying to say. Yeah, so basically that's what happens in CJD, right? That's what happens in CJD. The next thing we're going to talk about the effective causes is actually HIV-associated dementia. This is also very high yield, but not so high yield. The only thing you need to know there, basically, for HIV dementia is that it's a form of dementia that causes in patients that have AIDS. It's actually an AIDS-defining lesion. But before I go further, can anybody tell me the CD4 counts that a patient will have in order to have HIV dementia? What's the CD4 count?
Less than 200 already.
Yes, yes. So less than 200 is the answer. Less than 200. The patient will have less than 200. So you guys should know that, because sometimes they can bring that as a question. Oh, the patient has HIV dementia. Usually they'll tell you that the patient has depression. One of the key features of HIV dementia is that the patient will have a lot of confusion and depression. So the patient will be confused and depressed, right? When the patient has that confusion, depression, irrational behavior, and talk. So these three things are pathognomic: confusion, depression, irrational behaviors, and talk. When you see that in a patient that has HIV, the patient has HIV dementia. Those three things are characteristics. You must know that thing. You must know it, right? Then another thing you need to know is that there's a particular cell, a particular supporting cells that are implicated in HIV dementia. Can anybody tell me the name of those cells? Yes, so
Then the CNS, the microglia, like macrophages,
Yes,
they attack in the
yes,
late stages. They affect the microglia or macrophages.
yes. So the microglia are the cells that are affected, and in the late stages, you now have what we call multinucleated giant cells, which are what you see in tuberculosis or chronic chronic infection. Dr. Victoria, do you have a question?
No, I said when you said a multinucleated cell, I also said it could also be seen in syphilis associated encephalopathy. You can find multinucleated as well. I don't know if you're aware of it.
Okay. Okay. Okay.
In syphilis or in tuberculosis, you know.
I think it's TB that you see that. Are you referring to Guma?
Tuberculosis, I think not in syphilis, that the giant cell is not syphilis. In viral infections in the CNS, you know, and in tuberculosis, what I know. For me also the first time the syphilis. I don't know.
I know I've come across syphilis associated encephalopathy having that multinucleated. I also stand to be corrected, but I know I've seen that. If it's not in syphilis, then that's okay.
Okay, no problem. I think what we need to do is that we should research about it. But I think I don't know whether you are referring to Guma, but it's okay. I'll research about it. I'm not really sure multinucleated giant cells are seen in syphilis too, but I'll research about it and I will try to clarify that. Yeah. So somebody said in tertiary Guma, yes. So I know that in tertiary Guma you would see multinucleated giant cells. I don't know. Yeah. So yeah. So I said for the HIV dementia, the patient presents with confusion, the patient presents with depression, and then the patient presents with irritability, irrational talk, especially where the patient just keeps saying things, features like encephalitis in a way. So the patient presents with confusion, depression, and features of encephalitis along with dementia. So that's HIV dementia. That's another effective cause of dementia, basically. So I think I'm done with the effective cause. Do we have any questions as regards the effective causes of dementia?
So you only mentioned two under infectious, right? You talked about the EJD and HIV-associated encephalopathy. Is that correct?
Yeah. So
You
I
mentioned.
said.
Okay.
Yeah. So I said there are two causes of HIV. Or no, two causes of infective dementia, basically. And the first one is CJD. The second one is HIV dementia, right? So I talked about CJD.
Okay.
Yeah. So I hope you got all the explanations concerning them.
Yes, I did.
Okay.
Thank you.
Yeah, so we'll go to the vascular dementia. I want to attend to the genetic last because it's longer. So the vascular dementia basically is found in patients that have other comorbid conditions such as DM, hypertension, smoking, and the likes, right? Okay, so vascular dementia. Now, there's another thing you need to know about vascular dementia, right? So what happens in vascular dementia here basically is that the patient has a stepwise decline. Let me explain what that means. Let me just explain what that means basically. Right. So the patient is at this point in terms of cognition, and then the patient declines. He stays in that level for a very long time, right? And then the next year, let's say he's 60 years of age, right? He declines, right? When he becomes 61. In 61, you stay at that level of decline. And then when he becomes 62, he declines again. That's his cognition declines. That means he has cognitive impairment. That means what I'm just trying to say is that over time, his decline becomes more frequent and then it becomes more severe. So let's say at this point here, he could remember his birthday, his name, his age, his wife's name, his children's name, then he now declines. So he will not be forgetting maybe his account number. He will stay in that level for a while, that he's forgetting his account number, but he's able to remember his name, his family name, his wife's name, his address. But he can't remember his account number. He will stay in that stage for a very long time. And then the next year, he will decline again. So this time, he will be able to remember his name, his age, his family name, but he will not be able to remember the address of his house and then his account number. And then he will stay in that level again for a long time. And then he will decline again. When he declines, he will be able to remember his name, his age, his family name, but he won't be able to remember, let's say, maybe his bank account, his address, and then maybe his last born's name or his last child, the name of his last child. And then he will stay in that level again. And then the same thing, go down. So that's what happens with vascular dementia. And people who are at risk are patients who have diabetes, hypertension, and the likes, right? The part that is affected in vascular dementia is usually the subcortical regions. So the parts beneath the brain that's responsible for memories, the limbic system is one of them, right? Subcortical regions. So subcortical just means every other part below the cortex. So every other part below the cortex is the part that's affected. So you have the limbic system, the basal ganglia, regions such as that, just below the cortex, basically, is the part that's affected in vascular dementia. And on CT scan, what you see for the patients is that you see multiple subcortical infarcts. Okay, when we start doing images, I'll show you guys this thing a lot more better. When we want to end the topic, I'll show you guys. So this is what I'm trying to say here. So you can see these are subcortical infarcts, these white hyperdense areas here. This subcortical infarct, these hyperdense areas here we are seeing a subcortical infarct, this here. Right? But when we start doing images, I'll get clearer pictures and I'll show you guys a better illustration of vascular dementia, right? So, do we have any question as regards vascular dementia? Now, there's a difference that we need to be able to differentiate between vascular dementia and dementia secondary to Parkinson's, okay? So when these motor symptoms lag, so let me use it like this. Let me write it like this. So when the motor lags the cognitive function, the patient has vascular dementia. What am I trying to say basically? I'm trying to say that the cognitive dysfunction starts first before the patient starts having motor dysfunction for vascular dementia. But in patients with Parkinson's disease, very, very important, you should know this. In patients with Parkinson's disease, right, or dementia secondary to Parkinson's disease, the motor symptoms starts first before the cognitive functions, right? In dementia secondary to Parkinson's disease, motor symptoms starts first before cognitive decline. I don't know if we understand what I'm trying to say here. So the patient will present with slowness of movement and all the likes. Yeah,
Yeah.
you will present with slowness of movements. Yeah, before the cognitive decline, before the patient starts having memory loss,
Yes, that is
and all that. Exactly. But in patients with vascular dementia, the patients have cognitive decline first. This stepwise decline in cognition will present first before the patient starts having motor symptoms. I don't know if that is clear.
yes, it is.
Yeah. Okay. Do we have any questions as regards that? Okay, so let's move on to the other ones, right? These ones are very long. I'll just try to summarize it so that we can try and finish this as much as possible, right?
Doc, sorry, this is neuro. When you load it into the brain, it'll be difficult to comprehend these things. I mean, this is fine, but for me, I'm thinking 2 hours. We have a lot to go through, and then we have to retain as well. I don't know about
Yeah.
others, but exhaustion and headaches are stepping in for me.
Okay. Okay, so you want me to reduce the amount of time I used to take it,
Yes, I
or I
think
should?
2 hours for me is enough. Yes, and this is neuro, so we need to,
Okay, so let's get an opinion poll. Guys, do you want me to spend more number of times in neuro, or I should just make, because I'm supposed to just take it for 1 hour, but because I want to break these things down
this
for you
is two
guys, I want
hours
to make sure
already.
you guys.
Doc, we're two
Yeah.
hours gone already, and we have to really understand this one, the ones you've already taught, right?
Yeah,
Then
yeah.
be able to have an open brain to get the other ones.
Okay. So do you
Then
guys want?
the time is not important. The most important is the concept is, you are doing very well, and
Yes, that's true.
our crystal clear concepts about the things. I think it's more
I think two
important
hours is
than the
perfect.
time. If you do in the one hour and we just learn only the headache, we will not cover in the 1 hour all the things. The second, you are doing very well, very with your pace is very exactly, the normal, and you repeat the things multiple times. They definitely it time taken things, and we definitely, very thankful to you. You are giving the time, it's 2 hours, and we are getting a lot of clear concepts from this, time from you. I think
Okay.
this is the perfect, 2 hours. I totally agree with this time, man.
Yeah, I mean, two
Okay.
hours is great. I'm saying like extending 2 hours would be too much for me. That's why I commented that this is exceeding 2 hours already because we've done 2 hours, and this is neuro. So um for me, I think 2 hours is just great because if you go up on and on and on, yes, your concept, everything is good, teaching is perfect. That's granted. It can't even be argued. But for we on the receiving side, or myself on the receiving side, I need to still go back and reread these things and have it well understood and
Yeah,
all
sure.
that. Yeah, that's what I'm saying. I
Yeah,
think
sure.
2 hours.
Okay, so okay, that means we're going to stop here today. We're
Yeah,
going to
thank
continue
you.
here tomorrow.
Yeah,
Yeah,
I
yeah, so
agree
that
with
I don't.
Dr. Victoria. 2 hours max
Thank
is
you,
after
Abuna.
that we going out.
Mhm.
Yeah, I'm
Yeah.
really sorry for. I'm really sorry for taking too long. I'm really sorry, guys, for taking too long. I want you guys to understand these things. I just see you guys in my own shoes about 2 years ago, and I just want to make sure that you guys when you are reading this thing, it's very easy to just understand, right? So 2 hours maximum. I'm not going to go more than 2 hours. Yeah,
Thank you.
And you're
yeah.
doing great. You don't need
An
to
awesome class.
apologize. You're doing a great job. It's just like because we need to go over and revise, and then we have Ural class and all of that, we still need time. So take your time explaining. You're doing a great job.
Okay. No problem, guys. So we'll stop here today, and we'll see tomorrow by the special grace of God.
Thank you so much. I appreciate
Yeah,
all
Yeah,
this.
thank you. Thank you.
yeah. So yeah. Take care, guys.
All right. Bye bye.
Yeah.
Thank you.
understand it. So it's not about loading and loading it. It's all going back. And that everybody starts saying, I agree with Dr. Victor. I agree with Dr. Victor. And even that girl that wrote on the group chat that said that he wasn't good.